vacuum-assisted delivery of corneal tissue, a novel technique for endothelial keratoplasty. Decimate stripping with endothelial keratoplasty is a technique that aims at removing damaged or diseased endothelium and replacing it with a donor lamellae containing healthy endothelium. Most popular technique involves transplanting the posterior 150 microns of donor corneal tissue that is prepared using either manual or automated preparations. Dsaek is started by first marking the surface of the cornea. A 4 to 5 mm sclerocorneal tunnel is made without entering the anterior chamber. An irrigation cannula is introduced into the anterior chamber and the reverse Sinski is used to score the endothelium within the initial corneal markings. The scoring process is done in a 360-degree fashion. Trypan blue helps in visualizing the Dsaek membrane to be removed with the aspiration cannula. A microkeratome is introduced into the anterior chamber, followed by a crescent blade to widen the sclerocorneal tunnel to its desired width. The donor lamellae is folded upon itself and introduced into the anterior chamber with forceps. An air bubble is placed in the anterior chamber to help with the unfolding and stabilization of the donor lamellae. Postoperatively, the donor lamellae can be visualized by direct and focal illumination. Compared to traditional keratoplasty, Dsaek provides a structurally more stable outcome, a quicker rehabilitation for patients with minimal to no postoperative astigmatism. On the other hand, Dsaek can be technically challenging to learn initially. There is a potential for large endothelial cell loss that may affect the long-term survival of the graft, and there is a risk of flap dislocation that might require a reinsertion of the air bubble, a repeat of the Dsaek procedure, or a conversion to traditional penetrating keratoplasty. The most intimidating step of the procedure is when using the forceps to fold the corneal lamellae and insert it into the anterior chamber. It is at this point that the donor lamellae and the recipient intraocular structures are most susceptible to damage. Confocal studies performed at the University of Pittsburgh confirmed significant endothelial and stromal damage induced by forceps manipulation of corneal tissue. This is evident by the red nuclei shown on the photographs. The Dsaek injector invented by Dr. Alghoul was designed to counteract the risks and complications of inserting the donor lamellae during the Dsaek procedure. The Dsaek injector is principally made of 4 components: a retractable metallic tip for the transportation of donor lamellae, a disposable acrylic cartridge to secure the sclerocorneal tunnel, a retractor guide that connects to the retractable metallic tip, and irrigation and aspiration ports at the rear of the injector to allow a stable anterior chamber during the transportation of the corneal lamellae. The retractable metallic tip has aspiration ports that will serve to secure the donor lamellae in place. Upon placing the donor lamellae over the aspiration ports, aspiration can be activated through either a phacoemulsification machine or a needle syringe that will cinch the corneal lamellae over the ports. This will cause a vacuum rise and stabilization of the donor lamellae in place. At the rear of the retractable metallic tip, there is an irrigation port that will allow for the slow but constant infusion of fluid that will serve to maintain the anterior chamber during the transportation of the donor lamellae. In this video, we demonstrate how the retractable metallic tip can slide underneath the donor lamellae from the stromal side. Upon activation of the aspiration system, the donor lamellae is cinched onto the aspiration ports and subsequently vacuum rises, thus maintaining stabilization of the donor lamellae in place. The rear of the injector features 2 ports to allow for the irrigation and aspiration tubings to be connected. By relying on the phacoemulsification machine, we can use the phagodynamics of the machine to maintain a stable irrigation and aspiration system through the process. The following video demonstrates how vacuum forces applied to the corneal stromal side maintains the corneal button in place. This allows for the safe transportation of the corneal button from within the acrylic cartridge into the anterior chamber. Please note that the corneal tissue is only rolled within the cartridge rather than being folded upon itself. As a result, no compression of endothelial cells occur in the process. The following 3D animations show how the Dsaek injector works. Upon placing the cartridge tip into the corneoscleral wound, a constant infusion of BSS occurs. The retractable metallic tip is then introduced into the anterior chamber with the corneal button sucked into the retractable tip. Upon placing the corneal button into the correct position, the suction process is reversed by the reflex on the foot pedal switch, and the corneal button is released into the anterior chamber. The retractable metallic tip is then retracted and the cartridge tip is removed. The following video done on a donor human globe demonstrates how Dsaek would work. The acrylic tip of the Dsaek injector is introduced through a sclerocorneal tunnel. This allows for the movement of the BSS solution through the cartridge and into the anterior chamber. Once the anterior chamber is stable, the retractable metallic tip holding the corneal button is introduced into the anterior chamber. As the tip is inserted into the anterior chamber, the corneal button will slowly unroll and lie flat in the anterior chamber. Aspiration is stopped at this point, and the reversal of the aspiration process is possible through the phacoemulsification foot pedal switch. This will help in releasing the corneal button from the retractable tip. The tip is removed from the anterior chamber and an air bubble is inserted underneath the donor button. While still investigational, this device has the potential to allow the safe and effective transportation of corneal tissue with the least possible damage to the cornea and intraocular structures of the eye. By minimizing the manipulation of the corneal tissue and maintaining the anterior chamber, the surgeon will feel more comfortable in operating by using the Dsaek technique. Furthermore, the advantage of this device is its ability to transport tissues of much thinner dimensions than the standard 150 microns. This will serve to be a better transportation device for handling thinner tissues. We hope that this device will provide a better outcome for our patients in the future.